Hello, students. Let's go through this outpatient chart. All right, so as we start with this chart, you see all the different orders from the nursing, back office, um, pregnancy. They did a pregnancy. They did orders for going home. We also have lab orders being done, urine analysis being done, CBC, metabolic panel, anyway, x-rays. We also have the CT with contrast. You'll see that coming up. Why we have metabolic. Okay, so medications, let's look at that. We have ibuprofen. We have ondansetron oral disintegrating tablet. That is for nausea, vomiting. This is the contrast here. Okay, so also if we go through, we start here with the HPI, history of present admission. Okay, so chief complaint was abdominal pain. So this patient came in with the mother. They're having sharp pain near the belly button, moved over to the right side, sensitive to touch, does not have a fever, nausea times a week, worsening, no vomiting, diarrhea. Okay. So with that, and energies decrease, cough, all of that. So one thing I can say, we are emergency department outpatient, right? We are looking at what they came in for, abdominal pain. And one thing I want to, a lot of you coded almost everything on this list. We are not going to code that because we're going to code anything that's going to be specifically kind of close to that abdominal pain. Um, Significant, the neurofibromatosis. Okay, it's something that a patient or a person is actually born with. Let me pull it up here. So with that, this just kind of talks about it's a medical disorder. Most tumors are non-cancerous. Okay, they have type 1. But if we go down here and look at the different things, um, increased risk of GI stromal tumors. Okay, so possibly this could have been causing, had something to do with the quadrant pain. Okay, brain tumor, no, we're not going to code any of that. We are not going to code the seasonal allergies. We are not going to code the hearing loss, okay, or the neuroma. Chemotherapy, we're not coding that. Keep in mind, this is outpatient. If we were an inpatient, yes, we're going to code a lot more of this. We also are going to code the Asperger's syndrome just because this could relate with the way that they possibly could treat a patient. Okay? Back pain, no. Degenerative disc disease, all of these we are not going to code. All right? Because once again, we are looking at why that patient came in for the abdominal pain and just a little background to this patient's history. But none of these diagnoses that I mentioned are going to make a difference in this outpatient visit. All right. So in addition to the medications, she's taken no other meds. Okay. Seasonal allergy medication. All right. So let's go down here. We have review of systems. They go through everything. Abdomen soft. Right here, RLQ tenderness. Okay. Interventions. This is what happened. We did do abdominal x-rays. They checked the urine. The pain did decrease. We did CAT scan, and then the patient signed out to the doctor at midnight for further care. All right, so then we go through all the blood work. Go down here, this one here. The lymphocytes are a little bit high. You can see the little asterisk here. No obstruction, CT CT with the abdomen, rectal IV contrast. Okay, so we have no consultants coming in. Medical decision making, right here we have the right lower quadrant abdominal pain. It is concerning for possible appendicitis. We cannot code for that because we are outpatient. Anything possible, we cannot. Bowel obstruction, pancreatitis are unlikely. Physical findings, response to therapy, plan to obtain a CT they plan to do this at a different times. We're coding just for this emergency outpatient visit. And that's why we don't want to code all of those procedures. The only thing, if you guys did read through the chart, pick through it, she was BPAP dependent. Okay, which that took the doctor by surprise. Because I kind of went through, I didn't see anything real respiratory. If anybody finds something that I missed, please let me know. With that, child sleeping on abdomen without obvious signs of discomfort. And I'm getting that the patient is over 12 years old because they did have tubes at 12 plus. So it's not a infant, toddler. I would say it's somebody over 12 but under 18. Just because they're not giving us the birth date or I've not seen an age. Okay, so recommendation here, it just kind of goes through that. All right, so coding wise, let's just pull this up, bring my thing over. Right lower quadrant pain, R1 0.31. This is going to be primary diagnosis. Remember, outpatient, we call it primary. Principal diagnosis is for inpatient. We are going to code the neurofibromatosis type 1. Okay, they were born with this, Q85.01. Also are going to code Asperger's. If you code it the Z99.11 dependence on BPAP, that's fine too. Like I said, reevaluate this because some of you had a lot of diagnosis codes, which this is a learning chart. I want everyone to learn from it. Oh, and I mixed up my two drugs here. This aluminum and magnesium is for throat lidocaine. This here is for the contrast that they did with the CT. So this is what I'm coming up with pertinent diagnosis that should be coded. Once you start throwing in all these other signs and symptoms or past history, the other thing I tell students also with past history is that it has to make sense for this admission or this time that they come in. Usually with ER outpatient visits, you're not going to have a bunch of diagnoses. Inpatient possibly, because if they're being treated or if they're on medication for that diagnosis, you are going to go ahead and code it. Or if it's making a solid reasoning to be treating that diagnosis, or if it's related to the principal diagnosis, you are going to code it. Hopefully this helps. If any questions, please contact me.